The following podcast is part of a certified educational activity titled Going with Your Gut, targeting long-term weight loss with current and emerging incretin-based pharmacotherapy. Access the entire activity and complete the post-test at peerview.com/FQJ860. Downloadable slides and practice aids are also available.
Welcome, everyone. Welcome to our program entitled Going with Your Gut, targeting long-term weight loss with current emerging incretin-based pharmacotherapy. I'm Dr. Christopher Still, and I'm honored to share the stage with the co-director of this course, Dr. Alan Whitgrove. He's going to welcome an introduction and talk about the current perspective of managing obesity and chronic disease. But I want to just point out that he's a fellow diplomat of the American Board of Obesity Medicine. So congratulations, Alan. Welcome to the club. And I would just like to point out that more and more surgeons are becoming obesity medicine certified, and it's really great. So without further ado, I'm going to turn it over to Alan, and welcome.
Thanks, Chris, and let me also welcome everyone as I begin with this outline on current perspectives on managing obesity as a chronic disease. As all of us know, obesity and clinically severe obesity is the pandemic that started long before COVID-19. And so just as there's been a vaccine developed for the treatment of the virus, we need to have strategies dealing with obesity management for patients who suffer with obesity and clinically severe obesity. We now know that we can stratify patients according to risk. Those patients with lower risk should have lower intensity treatment plans and therefore less risk from the treatment itself. Higher risk patients require interventions that potentially have more complications, but that's justified as well. So we can move from diet and behavior modification or lifestyle changes and into some of the obesity medications to achieve a better mean weight loss. But then, of course, patients who suffer with clinically severe obesity, our operative approaches are more appropriate. I think everyone has seen this slide or a variation of it, indicating that obesity is a chronic, progressive, multifactorial disease which is associated with severe complications. And it tends to be relapsing, and every body system is affected. I like this slide because it's more visually showing how some patients can have higher risk based on their visceral fat versus their adipose fat. We did some work looking at the differences in adiponectin levels, for example, in visceral adiposity versus subcutaneous fat, and it's clear that these two deposits are significantly different. Visceral adiposity, as we know, carries increased risk, and it's more metabolically active. This is why we can see in the medical literature that a 10% weight loss can have significant medical benefits because as much as 30% of the visceral fat is lost. So remember this slide as surgeons. When we try to optimize our patients preoperatively, we can have significant benefit with that modest preoperative weight loss. This is another way of looking at a similar story about how therapeutic weight loss reduces complications that we see in our patient population every day. Here again, comorbidities are complications. Each complication, as we reach that magic 10% weight loss, we have significant improvement in diabetes, hypertension, dyslipidemia, and even GERD and PCOS. So there's significant challenges, obviously, in long-term weight management for patients who suffer with obesity. There are physiologic issues, behavioral issues, genetic and environmental factors. And as we try to address significant weight loss, we need to take into account all of these different factors. Some are obviously easier to deal with than others. For example, it's difficult to change one's genetic code. But under physiologic, for example, we can prescribe alternative medications that don't have the positive weight effect. We can now alter physiology by administering gastrointestinal peptides and perhaps change the health conditions so that hyperinsulinemia is decreased. So now the patient can be more active, have a better emotional outlook, and therefore maintain their diet better. All of these factors need to be integrated into our approach. Because telling the patient, eat less, just doesn't work. The body is very effective at maintaining its set point. As this study shows, a 10-week weight loss intervention led to a 14% weight loss, but it caused sustained changes in 8 hormones, including leptin and ghrelin. And through these hormonal changes, then, the body tries to re-regulate back to its set point. So as we lose weight, there are metabolic signals to increase appetite and decrease our energy expenditure so that we re-regulate back to the set point. The same goes to some degree in weight gain. Those metabolic signals decrease appetite and tend to increase expenditure, again, to maintain homeostasis and to re-regulate back to that set point. So in order to achieve sustainable weight loss, we need to reset the set point. This is done through metabolic adaptation or physiologic changes. And as we see in this slide, bariatric surgery addresses those metabolic adaptations, whereas standard diets do not. For example, diets cause an increase in ghrelin, a decrease in GLP-1, a decrease in PYY, and all of those metabolic changes allow the individual to defend that higher body weight through these homeostatic mechanisms. Surgery, on the other hand, creates a metabolic environment or a physiologic adaptation which allows the individual to have a different or lower set point, with ghrelin being decreased, GLP-1 increased, PYY increased, etc. So here I am as a surgeon telling an audience, primarily as other surgeons, that there's an opportunity for weight loss pharmaceuticals in the treatment for obesity. As we all know, metabolic and bariatric surgery is underutilized, being used in only 1% of patients who qualify. And we've discussed for years the barriers for the use of this treatment plan. Primary physicians don't discuss the option. They have unrealistic discussion points about the effectiveness and the risk of the surgery. And there's economic factors to deal with as well. But for every problem, there's an opportunity. That means that pharmacotherapy may be used as an attractive alternative in 99% of patients eligible but don't have surgery. And this is the part that excites me the most, actually. This is the reason that I got my bariatric medicine boards. We see in this slide that bariatric surgery obviously works on the GI tract, and it alters a bunch of different hormones and mediators. But the obesity medicines work more centrally in the brain. And I view this as a huge opportunity, as these different modalities have different mechanisms of action and have potentially additive effects. And I want you to be open to this concept as we discuss a couple of cases and the evidence presented in the medical literature. Chris?
Thank you, Alan. Great job, as usual. This is masterclass number 1, evaluating the role of incretin-based pharmacotherapy in the context of bariatric surgery. So this is Brody. We're going to briefly describe Brody, then talk about some evidence, and then come back. But Brody's a 32-year-old man. He's in the 50-50 club, BMI 52, waist circumference 50. He has depression, early AM headaches, daytime somnolence. He's got what I call the Pennsylvania package: poorly controlled diabetes, fatty liver disease, obstructive sleep apnea, hypertension. And he's going to undergo Roux-en-Y gastric bypass in 3 months. So if we look at the evidence, we know, and Alan, there's a bunch of guidelines out there, and we know that these guidelines are probably 3, 4, 5 just on the medicine side, plus the surgical guidelines. And they all recommend, diet and exercise as first-line treatment. But why I like this ACE, American Association for Clinical Endocrinologists, it's really complication-centric. And so I think that's really important when we consider the disease, the chronic disease of obesity. So here we have, if they don't really have any complications, you can consider pharmacotherapy at a BMI of 30 alone, and consider bariatric surgery or metabolic surgery at a BMI of 40. But mild to moderate obesity-related complications, you should consider medications at a BMI of 27 and surgery at 35. And then greater than one severe, and I think this is really important, they recommend adding pharmacotherapy and consider surgery at a BMI of 35. I hope in the in the near future that add will be also added to surgery for a BMI of greater than 35. And also there's evidence, but limited, but more and more that early intervention is key for severe comorbidities or complications like diabetes, metabolic syndrome, fatty liver disease, to consider with a BMI greater than 30, because clearly early intervention is really what it's all about with regards to resolution of comorbid medical problems. So this is just looking at the rationale for adding weight loss pharmacotherapy to lifestyle intervention. On the left, you can see the waterfall plot that diet and exercise, as Alan said, the average is about 3 to 5%. Some people lose more and some people lose less. But clearly, with the addition of pharmacotherapy, you can see not only do patients lose more, but they also lose quicker. And I think that's really important, not only for adherence for the patient, but also to get their comorbid medical problems under control. And so I think that, as Alan said, for meaningful weight loss, to control these comorbid medical problems, whether they're pre-op or post-op or not, we really need at least 10% of that weight loss. And that's where really, on average, 3 to 5% with diet and exercise, we really need to use pharmacotherapy and or bariatric or metabolic surgery to reach those targets. And then this is just looking at the different medications, and we'll go into that in more detail, each specific one in just a minute. But this is not a head-to-head comparison. This is looking at the medications, and I like to look at this compared to placebo. All the medications, no matter which one you choose, has a significant increase in weight loss compared to placebo or diet and exercise. And so I think that's the take-home point, that we really need to think about pharmacotherapy early into intervention. And I know as surgeons, you guys and gals do that, but I think that we should look at that more because, as Alan pointed out, less than 1.1% of individuals undergo bariatric surgery. It's less than 1.5% of patients are prescribed pharmacotherapy for a variety of reasons. So that opportunity is, as Alan said, there, and we just have to have that conversation with our patients. So these are our pharmacologic agents that are FDA approved for long-term use for the management of obesity. And so we have, just at a high level, we have one of them is not systemically absorbed. The other 3 are centrally acting. 3 of them are PO, or tablets, or capsules, and then 1 is subcutaneous. So we have orlistat. It was FDA approved in 1999. It's a tetrahydrolipostatin. It was actually brought to market to lower LDL cholesterol, but it didn't do as well as the statins, and so it was FDA approved for weight management. It blocks 30% of all ingested fat. If you don't take fat, you really don't need to take in this to use this medication. It does nothing to existing adipose stores. The next is a combination of phentermine and topiramate extended release. So phentermine's been around a long time. It's from the Weintraub trials back in the 1950s, and then in the 1990s with fen-phen. So fenfluramine was taken off the market due to primary pulmonary hypertension, but phentermine has been around and is still around. It is actually the #1 prescribed medication in the country today. It's not FDA approved for long-term use, however. It's only FDA for 90 days, depending on what state you live in. But phentermine and topiramate extended release is a combination. So it's a GABA receptor modulating agent is the topiramate, plus the phentermine is the norepinephrine releasing agent. It's an appetite regulation, and it affects centrally acting appetite. The next one is also a combination of naltrexone and bupropion. Both have been around for 50 years. So bupropion is a dopamine norepinephrine reuptake inhibitor, and naltrexone is an opioid antagonist. So this is a little different, that this is an appetite regulation for satiety, but it also helps or alters the reward pathway in the upper motor neurons to helping with craving. And I think that's really important, because oftentimes we don't eat because we're hungry. We don't eat because we eat because we're not satiated or have cravings. And so this and the next one, liraglutide 3 milligrams, which is a GLP-1 receptor agonist. This is a sub-Q injection. This, along with bupropion and naltrexone, helps not only with appetite and satiety, but also with the craving. So I think that differentiates, those two differentiates from phentermine and topiramate as well. So the rationale for weight loss pharmacotherapy and the treatment of adjunct of obesity management, I think you pointed out beautifully, that counter-regulation of metabolic adaptation. So our body defends the adiposity, as Alan said. So it increases ghrelin, decreases GLP-1s, and reduces our metabolic rate to get back to that set point. So we need physiologic weight loss with either tailored physiologic lifestyle modification, which we'll talk about, pharmacotherapy, or bariatric surgery, metabolic surgery. So weight loss medications support the effort to make the behavioral changes that's changed in our brain much better. And so we can either do that with caloric malabsorption, which we talked about with orlistat, which is not really prescribed much to date, but also then either by appetite control, by centrally acting, as you alluded to before. So that's with the liraglutide 3 milligrams, the naltrexone, bupropion extended release, or the phentermine topiramate extended release. So there again, as we showed with those waterfall plots, greater weight loss, quicker weight loss, and better chances of improve those comorbid medical problems, that at least getting near that 10% magic weight loss that's needed. So we all know this, but I think it's important to note, because this is the most common question I have from both patients, but most commonly primary care doctor, is how long do you have to treat? And they always say, well, how long do you have to treat your hypertension and diabetes and other chronic diseases? But you can see on the left-hand side, this is a study looking with orlistat, and after about 1 year, they're re-randomized. So I'm sorry, you can see that there's the orlistat group versus placebo, and then after 1 year, they're randomized either to placebo or orlistat. And you can see the patients that were on placebo that were randomized to orlistat lost weight, and vice versa, the patients that were on orlistat were randomized to placebo, gained back weight. So obesity is chronic relapsing disease, and the pharmacotherapies are approved for safe and effective long-term treatment. And I think that's really important. And then on the right-hand side, this is a great study looking at liraglutide 3 milligrams. This was a study they looked at a run-in period with diet and exercise, individuals that reached at least a 5% weight loss. Then they are randomized to either receive placebo or liraglutide. So actually, the average weight loss was 6%, and so those were then randomized, as I said, to either placebo or liraglutide. And the liraglutide group had an additional 8% weight loss in addition to that 6%. So this is another way of looking at using pharmacotherapy, lose weight by, a very low-calorie diet or whatever short-term, quote-unquote, meal plan replacement, and then add pharmacotherapy for additional and maintenance. I think this is not a bad way to go, because patients want instant gratification, and when it's slow, they don't think it's working, or they're not getting their goals that they hope to. So let's look at the proposed mechanisms of actions for these GLP-1s. As I said, a lot of people think that they're just peripheral acting. They are produced by the GI tract and the small intestine from the L cells or the endocrine cells. And they do affect peripherally, most commonly is muscle, to increase insulin sensitivity and increase glucose uptake. They also affect the pancreas for increasing in insulin secretion, insulin synthesis. That also helps with beta cell proliferation and beta cell survival. But also in the liver, I think is really important because it's been shown to help with decreasing gluconeogenesis and decreasing steatohepatitis. So we're participating in a trial with semaglutide for SEMA-NASH, and there's several others, GLP-1s, that are in the works for NASH treatment. But what I want to point out, as you pointed out, Alan, is that really from appetite and satiety, these are centrally acting medications. And not only do they decrease appetite and increase satiety, but they help with that reward and craving pathway that we both said was very important. In addition, you can see that it has benefit effects on the heart, the GI tract, and the like. The other thing is that some of the GLP-1s are cardiovascular superior, meaning that patients that were on these agents had less cardiovascular events than the patients that were not. So if we look at just one study I thought was an interesting study out for 3 years with liraglutide 3 milligrams. This was the scale obesity and prediabetes study. This was a double-blinded randomized phase 3 study with adults with pre-diabetes. So they could have a BMI of 30 alone or 27 with comorbidities. They just could not have diabetes. And you can see on the right-hand side, compared to placebo, at the end of 1 year, there was 9% weight loss. At the end of 2 years, there's continued 8%, and up to 3 years, sustained weight loss of 7.3%, I think, versus placebo, as you can see at the top. So there again, effective, sustained weight loss for 3 years. What I'd like to point out to the right, you can see when the medications are stopped, there is a slight progression or increase in weight. And, we know that, and there again, as we talked about before, the need for chronic treatment. If we look weight loss by category, this is just categorical weight loss. You can see some 50% of patients lost at least greater than 5% versus half of that in the placebo. 25% lost greater than 10%, and 11% lost greater than 15%. That's the categorical weight loss that the FDA requires. So pretty impressive in long-term, which is not only the efficacy has been shown to be effective, but the safety profile also has borne out in 3-year studies. So, and if we look at adolescents, and this is a huge area of opportunity. I don't know if you operate on adolescents, Alan, but we don't, from a medicine side, we really don't have many tools in our toolbox for adolescents and children, for that matter. Orlistat was FDA approved. But now, as of last year, liraglutide 3 milligrams was approved for adolescents age 12 to 17. And this is just a study showing the significant benefit or significant weight loss and change in body weight versus placebo in adolescents. And then this was a study that just came out in New England Journal, Lundgren, just this year. And this was a little, not surprising, but it was curious that I always thought, exercise was really important, not so much for weight loss, but for weight maintenance. But this was a nice study that showed that, you can see the exercise alone is in green. And compared to placebo, there was significant weight loss. And then liraglutide is in blue, but the gist of this, the combination of liraglutide plus exercise had a significant increase in weight loss and sustainability. So, I think that's really important. There's a lot of benefits of exercise, and it's really important, I think, in post-bariatric patients, but I thought this was an interesting study. So this is the exciting part, I would say, the additional incretin-based therapies that are currently in development. So we have semaglutide, the oral, We know that there's a semaglutide on the market today for diabetes, but they're looking at the oral semaglutide for weight loss. There's a benanglutide, I think that's how you pronounce it. That's a once a day injection that's approved in China. And you can see that there is about a 13% weight loss over 3 months in type 2 diabetics. That's pretty impressive. If you look at most diabetics studies with pharmacotherapy, it's about 8 to 9 to 10%. So anything over 10% is in my opinion, pretty impressive. Tirzepatide is a Q-weekly injection. This was also in trial with type 2 diabetes in the GLP-1 in combination with glucose-dependent insulin-trope polypeptide, or GIP. It's a dual agonist, again, 13% weight loss in type 2 diabetes. And then there's a combination of a glucagon and GLP receptor agonist, and that was a 3.4 weight loss over 49 days in a phase 2 trial. And then what is very impressive, I think, is semaglutide 2.4 in combination of an amylin analog. But you can see here, Alan, 17% weight loss at 20 weeks in a phase 1 trial. So that's really exciting, I think, what's in development.
Yeah, that's pretty amazing.
It's only phase 1, but the good news is, I want to just briefly go through these semaglutide 2.4. So this is the STEP trial. So semaglutide 2.4 is at the FDA right now and expected to be FDA approved. So if you look, the STEP 1, these were non-diabetics, but you can see compared to placebo, the semaglutide 2.4 had 15%, nearly 15% weight loss, which is pretty impressive. The STEP 2 was in the type 2 diabetics, and you can see about a 9%, almost 10% weight loss in the semaglutide 2.4 versus the semaglutide 1.0 had 7% versus 3.4% in the placebo. And finally, the STEP 3 with no type 2 diabetes, but with intensive behavioral therapy, there was a 16% weight loss versus 5.7. What struck me, Alan, on this, if you look from the STEP 1 to the STEP 3, the intensive behavioral therapy traditionally adds a significant amount of weight loss. But, this is curious that, is 15 just to 16%. So that to me shows that this medication, the semaglutide, may be the real deal in really changing, significantly causing significant weight loss. But the intensive medical therapy may not be as important as, the current medications are with diet and exercise and behavior modification.
Yeah, it's intense on its own.
Yeah, good point. Well, maybe like, the statins, this is what I remember, before the statins, we really relied on diet and behavior modification to control cholesterol. Now with the statins, that's really hardly, talked about. So
right.
Same thing with antihypertensive, that was, diet modification was also important. All right, and then finally, this is just the step 4, which I wanted to look at with regards to weight maintenance. So this was semaglutide 2.4 for 20 weeks, and then they were re-randomized either to receive continued semaglutide or placebo. So they wanted to see how semaglutide did for maintenance. And lo and behold, significant continuum of weight loss. And so at the end of that year, there was, again, an 18% weight loss compared to the patients that regained when they switched to placebo. So let's talk about Brody in a little more detail. As I said, he's 32. He's a body mass index of 52 with a waist circumference of 50. He has depression on paroxetine, signs and symptoms of obstructive sleep apnea with early morning headaches and daytime somnolence. He has poorly controlled diabetes, fatty liver disease, obstructive sleep apnea, and hypertension. So he lost about 5% in the first 3 months, which was what you would expect with diet and exercise. And then he's planning on gastric bypass in 3 months. And so, preoperative weight loss, you and I may differ on this, but I don't really think so on this high-risk individual. I'll let you chime in first.
Yeah, I mean, if you look at just body mass index, from a bariatric surgeon standpoint, anytime you get over 50 BMI, the complication rates are higher. So trying to get any individual, doesn't matter if they have diabetes or sleep apnea or anything else. I mean, you want to optimize those things as well. But just from the BMI standpoint, you want to get that person under BMI of 50 if at all possible, because that globally cuts down on complications.
Yep. And there again, to drive home the point, is very few, I wouldn't say very, infrequently we're able to do it with just diet and exercise. So we really have to, I would consider pharmacotherapy preoperatively these. But I just want to be clear, I don't think that mandating weight loss is necessary, but I do believe in these, to optimize patient care, it's important. And just as we have here, poorly controlled diabetes, fatty liver disease, obstructive sleep apnea, I think the surgeons do a great job in screening, but it is really, there's significant amount of, fatty liver disease and obstructive sleep apnea, and just a modest weight loss of that 10% has been shown to normalize AST and ALT 50% of the time and decrease apneic episodes 50%. So it can be very rewarding in a very short amount of time prior to undergoing bariatric and metabolic surgery.
Yeah, I agree wholeheartedly.
The other thing I'll just point out is depression. Don't forget to screen for depression. It's really common. And when we're depressed, we tend to self-medicate with food, specifically carbohydrates, that increase serotonin and give us that calm and content feeling. So this gentleman, he was on paroxetine, which is a great medication, but it can cause weight gain in about 22 to 25% of individuals. So having said that, the iatrogenic effect of medications is real. It's estimated that about 10 to 15% of the obesity population is because of what we prescribe. And so I think taking a good medication history is important, and try to prescribe alternatives or decrease the medications that's causing weight gain is really important. So these are the medications that we talked about before. The contraindications, really, orlistat, it's very safe. It's the treatment effects. Phentermine and topiramate, the big thing is the fetal toxicity with the topiramate. So any women of childbearing years, you probably should not use this medication. And it can cause dry mouth, paresthesias from the topiramate. But it's very effective, as we talked about. Naltrexone and bupropion, the two biggest things with this is seizure disorder, because bupropion lowers the seizure thresholds. And obviously, patients on opioids will not be your friend if you prescribe naltrexone and bupropion, because it will block that. Nausea is the biggest issue with that. And then finally, liraglutide, the GLP-1s, is contraindicated with medullary thyroid carcinoma, or MEN2, or acute pancreatitis. And there again, the common side effects are nausea and vomiting. All right, I'm not going to go through this, but this is just the dosing consideration for your dosing administration for your consideration for prescribing. Most of them are escalating doses because of the nausea. One thing in the studies, there are forced escalation. In real world, you can slow down if they have the nausea. So I'll just turn this over to you, and you can wrap this up, Alan, if you don't mind, about this.
So from the standpoint of emerging weight loss therapeutics, how does this meld really with the surgery? Bariatric and metabolic surgery obviously is very effective, but in fact, we'll see in a future slide, there are different trajectories. And so we need to think about differences rather than restrictive and malabsorptive. All the other ways, all the other types of activities that we can modulate now to get a better weight loss, a better trajectory even after surgery. So I like to combine these therapies because they can be additive. And here we see that adding GLP-1s or some of the more centrally mediated pharmacotherapies can assist us in having even better weight loss and resolution of comorbidities.
Excellent. Thank you, Alan. All right, Alan, let's take us home with the second and last master class. So this is evaluating the role of incretin-based pharmacotherapy to enhance weight loss and mitigate weight regain after bariatric surgery. So this is Marissa. She's a 50-year-old postmenopausal woman, had who had gastric bypass 2 years ago after a cardiac stent placement. Other preoperative complications, she had NASH, fibrosis, hypertension, depression, and tobacco use. You can see that her BMI is 48. Prior to surgery, she had preoperative weight loss of about 12%. Her BMI at the time of surgery was 43, and then she lost about 60 pounds and then plateaued, and then we intervened with pharmacotherapy. So we're going to talk about when to intervene, the role of pharmacotherapy, and when is it appropriate to reoperate. So if we look at the evidence, as you pointed out, there is a variability even in surgery. Even though surgery is the most effective and durable treatment we have, obesity is so chronic and relapsing that, even with the duodenal switch, we have patients that gain back weight. And so you can see, just like any other treatment modality, is that bell-shaped curve. So it'd be nice to try to predict, if you will, which patient is going to do best on which procedure. I'm afraid I'm not as good at doing that as I had hoped to be, but just because there's a lot of variability in weight loss after any type of treatment, including pharmacotherapies. We looked at these, water plots before. So this is what you were talking about, Alan. This is a great slide.
Yeah, I love this slide. This is from the labs data, and it shows that after about 6 months, we can look at each individual patient, and there are different trajectories. Some patients fail to lose any more weight for one reason or another, if it's their genetic pattern or what, after that 6-month period of time. We like to have all of these plots in one line, and they go to a nadir, and then they come up a little bit. But the reality is all those lines separate out into these different trajectories. And I think it's really very important now to look at the patients, follow them closely, obviously, up to the 6-month period. But then after that, and if they're in the wrong trajectory, add medications to put them in a different trajectory.
Yep, we're going to talk about that because I think I'll hit it home again. Early intervention is key because you want to mitigate the weight gain because then you're behind the 8 ball.
Yeah, completely.
So these are just some strategies, converting, and you can talk about the surgical management. I'll just briefly talk about, dietary indiscretion. The further out is very important. So continued accountability and education is really important. Behavioral treatment is important. Exercise, drinking their water, all of that plays into making weight loss not only achievable, but long-term. And so it doesn't really matter what surgery, but I'll let you talk about, conversions and when's the right time to convert or reoperate.
Right. So surgical management obviously is important, but it's really interesting when you look at why we did a lot of conversions or revisions several years ago. The lap band, for example, I almost don't take out bands now for weight regain or insufficient weight loss. I add medications. And so if they have a complication of the band, then I'll take out the band. The same way with sleeve gastrectomies, if they have insufficient weight loss, I'll add medications to that if the sleeve still looks okay and they're not having bad reflux or other complications of the operation. And in the same way with the gastric bypass. If the pouch looks fine, I haven't had much success really with changing the anastomosis, but if the pouch is okay, then medications are usually better option than a risk of a revision type of surgery.
Great, thank you. We don't have, in the instance of time, I'm just going to go through these quickly, but there are some studies and recent studies showing just that using incretin, specifically liraglutide 3 milligram for insufficient weight loss and excessive weight gain after metabolic surgery. So there's, some larger studies than others, but, this was a nice study that was just published this year, I believe, by Godsda, looking at intensive medical therapy, a non-GLP-1 with intensive medical therapy, and a GLP-1 with intensive medical therapy. And lo and behold, the GLP-1 with intensive medical therapy proved to be the most effective. So just exactly what you said. I think using this in common in treatment with bariatric surgery, very similar to oncologic surgery. You use surgery and chemotherapy. I
Sure.
think that is an analogy that I think most people can get their hands around. So let's go in a little deeper dive about Marissa. So as I said that she had gastric bypass 2 years ago, I think this better depicts what I was just alluding to on the previous slide. So this is Marissa's weight trajectory. So when she first came in to see us, she was 350 pounds, had a BMI of 48. And as you recall, she had depression. She had bad sleep apnea. She also had smoking. She also was smoking. So with her, we talked about that physiologic behavioral changes. So with her, she was on a low-fat diet, which was all, breads, pastas, rice, potatoes, corn, cereals, all non-fat, but very high causes very high in insulin. And so she actually gained weight. So we switched her over to a Mediterranean-type diet. We treated her for obstructive sleep apnea. We got her more less sedentary or more active, and we treated her for depression. And she lost about 3 to 5%, which was good. And then I added naltrexone and bupropion, again for that dual benefit that we talk about. And then she lost another 6%. So all in all, I think she lost about 10 or 12% prior to undergoing gastric bypass. And so at the time of surgery, I think she was about 310 pounds. And so you can see the lines that are there, the red, the blue, and the green. So those are from our Get to Goal app, which I'll talk about in just a minute. It's a personalized app to track weight loss after surgery. And so we have patients weigh themselves on a weekly basis. And basically, if they're not going below the blue line, or so that's the 50% of what we expect, then we intervene. And you can see at that 6 months that you talked about, Alan, that were very important, she plateaued. And so at 9 months, we intervened with liraglutide, and lo and behold, she continued with her weight loss down to what were our expected and hopeful weight on that green line. And she's, to date anyway, kept that off very nicely. So there again, as you alluded to, early intervention, so you don't want them to start to gain weight prior to intervening with medication. And as I talked about, I liken it to oncologic surgery. Use chemotherapy in addition to surgery for cancer. I think using bariatric and metabolic surgery in addition to pharmacotherapy is often needed. And so the last couple slides. So as you pointed out, to the set point, and so this is an example of the blue line. This is when an example of someone that came in with a BMI of 40. So we put her on that physiologic lifestyle modification. She lost about 3 to 5%, and she moved her set point to defend a new set point. Then we added anti-obesity medications, and this example was the naltrexone and bupropion extended release. And there again, she lost another 3 to 4% for a total of about 12%. Then she underwent bariatric surgery, had a significant weight loss, and then finally, after she plateaued prematurely, we added the liraglutide, and the weight loss continued. And so to overlap what I just said, so you can see this was Marissa when she came in. At her baseline, she had that physiologic lifestyle modification. We added the anti-obesity medication. Then we added bariatric surgery, and then post-operative anti-obesity medication. Again, moving the physiologic weight loss to defend a new set point. We talked about a lot of these things, just how the GLP-1s can play in improving, or in addition to the physiology that you guys do with metabolic and bariatric surgery with incretin-based treatment. I'll just talk about depression and mental health issues following bariatric surgery. It does a lot of things, but depression can and does occur after metabolic and bariatric surgery that can inhibit weight loss. And as I alluded to, this is our free app. You can download it at the App Store, but this is called Geising or Get to Goal. So patients can put in their weight and it'll give them their expected weight. It's based on the BOLD database of over 150,000 patients. And it's just a good tool to keep patients accountable because we all need that for the patient's long-term success. So we talked about this before. When you do initiate pharmacotherapy, you want to check in 3 months to see if they're effective. If not, if they haven't lost at least 3%, they should consider non-responder and try something else. And then you really want to check on these individuals every 3 months to see how they're doing. So I think we've said it all, Alan. It was a pleasure. I'll just go through this conclusion summary if you don't mind. So as we said, modest weight loss can provide significant health benefits for individuals with obesity, contributing to multiple factors of behavioral, genetics, environmental, and physiologic can make weight loss challenging. Remember, our body defends its adiposity to try to gain back weight. So physiologic weight loss of pharmacotherapy and bariatric and metabolic surgery is really important. And including these changes in incretin hormone levels to help patients with obesity achieve weight loss goals. And then finally, and I think most importantly, is continued accountability and follow-up for long-term weight management is important. We have we have time for a few questions, so I'll just start them off. So the first one says, do you offer weight loss medications to patients who are willing to take them episodically only for a few days and to lose only a few pounds?
Well, I think this would be an interesting question back and forth. I'll tell you our feeling about it is, yeah, we do. People have different reasons to lose weight, right? And some of it is in conjunction with what our thoughts are to improve their health. Sometimes it's just to look better at a particular event. And so we give people that, and hopefully they'll stay in touch with the program. So episodically, maybe we can turn it into a more constant thing. How about you, Chris?
Yeah, I think that's reasonable. We always say that obesity is a chronic relapsing disease and, you need treatment long term. But I think for this individual that meets his or her goal, I think that's fine. But for most patients, I think you can agree that medications, are a chronic disease like any other chronic medication and need to be treated as such. But clearly, if patients can reach their goal, I always try to get them off of the medications. But 9 times out of 10, they realize that it was really helping them meet that goal and they go back on at some point.
Right. I think the key is that they stay in touch with the program.
Absolutely. And I think if it's effective, they will, because they want it back. They want to keep trying. That's another reason why we don't give refills. We only give 1 refills or so to keep them, coming home. It's like the kids, they keep coming back for their allowances, same type of thing. So here's one. What is a safe and expected time frame for patients to lose about 8 to 10% of their body mass?
So yeah, I'll give you the surgeon's standpoint, and you tell me from a medical standpoint. So from a surgeon's standpoint, let's say somebody's 300 pounds, they just have surgery, losing 10% would be 30 pounds. And that's very common to see that in a month. So I think it's very safe to lose 10% of your body mass in a month.
Yeah, I agree. I think for medical management, I was not thinking of safety as much as realistic expectations. How long will it take someone to lose, 8%? We know that on average, we want to see about a 5% weight loss in 3 months to make sure that the medication is effective and they're responding. So that's a good tool to use, that 5% weight loss at 90 days or 3 months. But I think 3 to 5 months from medical management, 8%. Clearly, it's, as you said, it's safe. The rapid weight loss of 8% over that much time is not that much. Okay, very good. This is another good one. It says the cravings are a major issue. Even after surgery, with the best intention towards improving behavior, many patients are caught in the cycle of eating for comfort and just need to eat. What is the best approach to combat this and give them hope that they will be in control?
Wow. Now that's That's a mouthful, right? But so I'm big into habits, right? So habits there are several parts to the habit. There's a cue, and then there's a routine that people do, and then there's a reward. And cravings play a huge part of that. And so you talk about the cravings in there. Um, so you try to figure out what the cue is and what the reward is. And usually it's not, the cue is hunger and the reward is satiety. It may be boredom and crunch, or who knows what, but that's the important thing. And then you try to change the routine so that the reward is still there. And but it's really important for the people to have the belief that it's going to work. So for example, if somebody is snacking at night as they sit down for watching TV. So the cue may be, boredom as they're watching TV, and the reward is kind of this crunchiness.
Mhm.
So instead of the routine being that they're going to have a bunch of nuts, which are mindless eating, they have some celery instead. So it'll be a negative as far as their weight is concerned, and it still offers them the crunch. So
Yeah, it's that stimulus control that they talk about.
yes,
You
so
know, and that's
you
really
have to
important
believe it's
because
going to work.
yes, we don't eat, because we're hungry. We just had a full meal and we go in to watch TV, and then the cupboards start to call. It's not that we're hungry, it's that as you said, we're not satiated. But I will just say that some of the medications, the anti-obesity medications, specifically liraglutide 3 milligrams and Wellbutrin or bupropion naltrexone, not only help with appetite, but they help with the satiety and cravings. And so if you think of a medication, an anti-obesity medication to help, those are the two that I would maybe consider, especially to help combat that craving. Because really, as I said, it's out of boredom or out of something else. It's breaking that cycle. And there is medications out there to help just specific that. And that's not unique to all of them. Just those two medications really help with that cravings.
Right. I think that's the important word in this particular question is the cravings, because the
Yeah.
cravings they're tough, right? And
Yep. Because you're true. It's not because we're not hungry. The other thing is we want to make sure they're not depressed, because sometimes when we're depressed, we self-medicate with food. And so a lot of times it's carbohydrates, which increases serotonin. So there again, getting to the root cause is, in the big picture, is much better for that patient. This just, than just to say, well, you need to do X, Y, and Z.
yeah, it might
Okay,
be
I think we have.
important to actually talk to the patient and listen to them.
Yeah, exactly. You do that. I don't do that. I just say, all right, I think we have time for one, maybe two more. This is a case, and this is really, I think, interesting for you. I have a 70-year-old male with type 2 diabetes that is 175 pounds after having a Roux-en-Y gastric bypass 6 years ago with a current BMI of 30. He lost 7%, but gained back 5. Or no, excuse me, he lost 7%, but gained back 2%. So my high-powered math, he has a net loss of 5%. His A1C of 6.5, his GFR is 36. He's on metformin 500 milligrams, and his blood pressure is well controlled. What pharmacotherapy, if any, would you recommend for him?
Yeah, so I approached this as the 70-year-old guy. He had his operation when he was in his 60s. His hemoglobin A1C level, is pretty controlled at 6.5, so that's not bad. It depends on where he wants to be, right? If he wants to be off all medications, if he's happy with his weight or not happy with his weight, if he's active or not. So, trying to get him back to being active off of as many medicines as possible, he's actually done pretty well. So I think, trying to find out where he wants to be. Certainly, if he's not active and he starts being more active, he's going to be a lot better off, both from his blood pressure and from his diabetes concern. So,
Yeah.
So that's where I would approach it, is just kind of seeing where he wants to be, and then add some medications if if he wants to go down further and get back to that magic 7%, he'll probably do really, really well.
Yep, I agree. I mean, his BMI is 30 and his A1C is down to pre-diabetes. So as far as medications, would I recommend for him, here again, a GLP-1 would be, I think, perfect. And there's been some data as we presented about using GLP-1s after bariatric surgery to help with not only weight gain, but, plateaus and continued weight loss. So
Right.
yeah,
it's a
I
perfect.
think in addition to the metformin, a GLP-1 would be great. Okay, we only have 1 minute left. I'm going to throw this out there because I think it's really good. And maybe I'll just answer it after I put it out there. 39-year-old female with history of psychosis. She's not a surgical candidate, has hypertension, cannot tolerate phentermine. Her insurance simply will not cover medications. What is the best choice for her besides remaining on her about diet and exercise only? So this is where I would try the dual benefit. I mean, I'm not sure exactly what her psychiatric history is, but that, those we know can cause weight gain, those medications. And we know that metformin in and of itself is good, is the best thing out there that we know of to help combat weight-related weight gain on psychotropic medications. But the other thing is I would look at that dual benefit. If depression is an issue, then I would look at, again, bupropion and naltrexone, which will help not only, with depression, but with the naltrexone will help with appetite. So there again, getting back on that or going back to that dual benefit. Yeah, I don't think phentermine would be great. And insurance, you're going to have to go with generics if there's no insurance coverage. And so that's why I would probably start just with Wellbutrin, say once a day for 7 to 10 days, and then add a little bit of naltrexone and see if that helps. Now you want to make sure that she's not on any opioids, or because the naltrexone is not going to be, she won't like me very well if it's going to block her opioid use. But that's what I would do for that. And I think that is a huge area of patients with psychotropic medication weight gain that needs to be continued to look at and to help these individuals that have tried everything and they're just gaining weight because of their medications. All right.
I have 1 second. I would say, I would add to that she may still be a candidate for surgery. I don't know why she's not a candidate if it's just her psychosis. I mean,
oh yeah, that's true.
Just because she's on psychotropic drugs doesn't necessarily mean
that would wipe out. Yeah, that's true. Yeah, I don't know. It doesn't say anything about her BMI or comorbid medical problems, but excellent point. I'm glad you brought that up, because just because they have psychiatric history does not make them not a candidate for bariatric surgery.
Right.
All right, Alan, I think we've said it all. Once again, thank you very much for your time. Thanks everyone for hanging in there, and have a great rest of your day.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/FQJ860. This activity is supported by an educational grant from Novo Nordisk Incorporated.